Good evening, everyone. This is Chitra from Huntington Disease Society, India. We welcome you all to the HDSI's 2 days conference. Today, being the second day, we have scheduled 5 sessions of 15 minutes each. And all the speakers today will shed some light on Huntington disease and other aspects of SD. Those who have missed yesterday's sessions, people do not worry because today's sessions will be equally helpful to all of us. Also, yesterday's and today's sessions will be made available on our website, that is sdsi.in, and our YouTube channel also. The links will be shared to you over email and WhatsApp. We request all the participants to make sure your mic is on mute. If you have any questions during the session, you can please send it in the text box, on chat box. All your questions will be answered after all the speakers have presented. We have kept a Q&A session for it. I would now request Dr. Meera Purushottam, who is an active member of the SDSI, to take over and introduce our speakers for the day. Thank you.
Welcome. Good afternoon, everyone. Thank you for joining. So we have a packed session today. So let's get underway right away. So our first speaker is Dr. Vikram Holla. So he's a faculty from the Department of Neurology at NIMHANS. So he has special interest in movement disorders, neuroinfections, neurogenetics, and neuroimmunology. And he's part of the movement disorder clinic. So he has been seeing Huntington disease patients and has considerable experience, which he is going to share with us today. So over to you, Dr. Vikram Holla. Let's start.
Thanks a lot, ma'am. Thanks a lot for the kind introduction. So I'll be sharing screen. Yeah, is my screen visible?
Yes, it's perfect.
And am I clear?
Yes.
Yeah. And at the outset, I would like to thank the HDSI team, Dr. Sanjay Jain sir and Dr. Meera Purushottam ma'am, for giving me this opportunity to speak about non-motor symptoms in HD. So when it comes to Huntington disease, more often we tend to concentrate on the motor symptoms and all the chorea, and that is visible outside most of the times. But there are many features that may not be visible outright, and we may have to tackle them, and there is an opportunity to treat them and give a better life for the patient as well as their caregivers. So coming to Huntington disease, it is there are three spheres. That is, in a common term, mind, mood, and movement. Or in a neurological term, there is movement disorders, there is cognition, and there is emotional abnormality. So these are the three aspects of Huntington disease every patient go through. So whereas the motor symptoms are like a chorea, dystonia, Parkinsonism, which we call as slowness, there may be impaired gait, balance, and posture. The patient may have frequent falls or tend to fall or feel like they are falling. And there may as well be speech abnormality and swallowing abnormality, because of which there may be difficulty conversing, making a communication, or also nutrition problem may also be there. Also, there may be early eye movement abnormality as well. But there are other features as well called as non-motor symptoms. These the symptoms which are not motor, that is the movement related. So those symptoms which are not directly movement related may be clubbed together as non-motor symptoms. As we all know, the patient, their caregiver, the doctors, everyone. So the major aspect of the non-motor symptoms are the behavioral and the cognition, that is the memory related issues that are most common and well studied, and we know a lot about them. But there are other non-motor symptoms as well, which a patient go through and which may be a burden for the patient as well as their caregiver. So why are they important? So it is important to know them because it may be the most problematic symptom rather than the chorea per se. Many patients, the hallmark motor features, the chorea, may not be troublesome per se for the patient, but there may be more worried with the behavioral and the cognition aspect, and also maybe other non-motor symptoms I'll be listing out. So it may be the most problematic, and if we are not tackling them, the patient will not be helping the patient or their caregivers. And many of the non-motor symptoms, although they are not curable, may up to a certain extent can be treatable with various pharmacological, that is medicines, as well as non-medical, non-pharmacological aspects as well, which can be employed by the caregivers and the patient themselves. So this is treatable and can be up to a certain extent. We can make the patient's life better and their caregiver's life better also. So non-motor symptoms may be the one of the major contributing factors to the caregiver burden. How the patients behave, the memory aspect, the inability to do day-to-day activities, constant supervision that may be required may add to the caregiver burden significantly. So this may be one of the major important contribution to the caregiver burden, and it may be present even in the pre-manifest HD. That is usually manifest HD. More often the patients may come with the motor symptoms, but it may be there very early and even before the motor symptoms. That is the involuntary movements. That is the dancing-like movements that we call it as chorea. So these non-motor symptoms may predate these motor symptoms and may be affecting their day-to-day activities, which they may not be aware of. So if the particular person is aware of these symptoms, they may come to a doctor or they may consult a doctor early and may get some treatment so that they can have a better life. So, so what is one of the most common non-motor symptom in Huntington disease is the cognition or the memory aspect or the cognitive ability. So this need not be only memory. It may be as well decision making. The patient may not be able to come to a particular decision. There may be errors in the decision, because of which if the patient is still working, there may be errors in his occupational area and may end up doing errors and may end up losing his job or losing a significant amount of financial problems may happen. Or even in day-to-day activities also, they may end up spending more, spending less. So these problems may happen. There may be difficulty in planning as well. The patient may not plan his activity, day-to-day activities, and also his occupational and as well as personal activities. The patient may not be able to plan. So we may think why the patient is not able to plan. It is such a simple thing, but the patient may be having some non-motor symptoms in the form of cognition, because of which the patient with HD may not be able to carry out his day-to-day activities. There may be lack of insight. We may be telling the patient, why are you doing this? But the patient per se may not have that insight. So the patient is not doing it because he wants to do it, but because he doesn't know that what he is doing is not appropriate. So they may have lack of insight. So there may be significant communication gap between the patient caregiver and the patient per se. So this may lead on to a significant burden and miscommunication. There may be rigidness. The patient may be rigid to particular fact or particular opinion. So this may again cause significant trouble and burden to the caregiver, and may have social disharmony and social interaction abnormality or social interaction problems. So, and there may be poor concentration. We may feel this task is so simple that it is so easy. Still, the patient may not be able to do that because of his inherent inability to concentrate for a longer time. So we may have to be a bit of patient, and we may have to give them time and avoid giving them more and more multiple tasks together, so that they may have poor concentration, because of which they may not be able to complete even a simple task uh, as expected. So this may be a symptom, and we may have to be, especially the caregivers may have to be aware of this, so that they should understand that this is not, I mean, the patient is doing this because he or she has lack of concentration and cannot be attentive to a particular activity, or it may be in the conversation as well. The patient may be jumping to different conversation, may not be able to follow a conversation. We may have to repeat the same thing again and again because he may be inattentive or may lack concentration, because of which may not be able to follow the conversation. And there may be difficulty acquiring new skills also. So we may teach them how to use a mobile, how to use a computer maybe, or how to use a new gadgets. The caregiver may be thinking this may help the patient. Let me teach that particular person these new skills. But because of this cognitive impairment, the patient may not be able to acquire new skill, however, how much ever simple they may be. So we may have to be a little, I mean, again, spend time with them, maybe make it simple, and tell it again and again without losing our patience. And we may have to spend more time with them. So these may be, I mean, may significantly affect the day-to-day activities, as well as the quality of life of patient, as well as their caregiver, because they may have to spend more time with the patient. So in how can we sort of tackle them? There are few non-pharmacological methods. I mean, unfortunately, by medication, there are very little we can offer. There are no definitive proven treatment that are available for memory. There are certain medications which may offer, which have been tried and have been proven to be a bit of benefit in other memory issues. But so we may offer some medication, but there may be other non-medication related non-pharmacological measures Like if a new skill has to be learned, so it is better if the skill is broken down into simple steps. So once one particular step is learned, then go on to the next step. So the patient is able to understand step by step, and you can compensate for the lack of attention and lack of concentration, and allow to plenty of time to practice, so that he or she will understand what is to be done, and he remembers that. And once that particular step is remembered, then go on to the next step, and use something like a checklist, so that they may have a visual this one, so it is done. So even if they forget, once they see the checklist, they may realize, okay, this is not checked, so maybe I have to do it again. So each and every step, if it is gone through the checklist, there is less chance that they will forget a particular step, and there is more chance that the patient may be able to learn a new skill. So there may be some other adaptive equipment we can use, walker, wheelchair, special settings. So we may have to teach them properly with time. So how to use very important. And for memory issues, we can many patients or caregiver may already maybe doing this. We can place a blackboard on the fridge or any area where the patient will be frequently seeing on the door, behind the door of their living room or the bedroom, where we can write down each and every activity scheduled for that particular day, any important events, so that the patient themselves may not feel bad that I forgot this. So they may be able to recollect, or if they have forgotten, they may go there and see the board and realize, okay, this thing I should have done. So let me do this. So they will be more involved in the family matters, and they will be happy that they are able to recollect them, and they are able to do those things, and it will motivate them further to get involved in the family matter and improve their quality of life. There may be other mood and behavioral symptoms as well, like depression, apathy, aggression, irritability, anxiety, impulsivity, impulsion to do something suddenly without thinking about what it may lead to, suddenly blurting out something, suddenly going and buying something. So these may be there. So the caregiver and the doctor should not get annoyed or lose patience with this deficit in a particular patient which is not under his or her control. So these also, like apathy and all, we have to encourage the patient more and more, involve the person in the family matters, try to involve him in the conversation. Even if the patient cannot follow the conversation, give him time, repeat it again, so that they will feel they are part of the conversation, and they will be motivated to be part of the conversation further. They should feel motivated that we are still belong to a family, and people are not neglecting me, people are not avoiding me. So these confidence and hopefulness should be instilled in the patient, so that they can feel better. This will also help the caregiver, because once the patient feels better and motivated, he or she may be more involved, and the caregiver also feels happy that, okay, I mean, he is a part of family. So when we are conversing with the patient, we may have to try to keep ourselves calm. So keep a nice, relaxed atmosphere. Don't show it on your face that you're angry, annoyed, because even though they forget the things, but looking at the face, they can understand, okay, this person is annoyed at me. Why is he or she annoyed at me? And this may make the patient get withdrawn and not involve or not participate in a conversation. If there is any confrontation, try to avoid it, and do not make it worse. And also try to get them focused on something else if they are having confrontation or any bad behavior or any bad feeling, and try to keep a routine, so that every day if the same thing is being done and done and done, there are higher chances that they will be able to recall and recollect, and they may end up doing the same thing, and they will feel that he is not forgetting, or he or she is getting involved more. There may be other non-motor symptoms as well, like pain. In a study, it was shown that up to 40 to 60% of the patients had some form of pain. More often than not, it may be because of the underlying depression, but it may be because of the motor symptoms also. And pain and all, we may be able to treat up to a certain extent and make the patient feel better by giving either simple analgesics, or trying to know why this particular pain is there. Is there any underlying depression that we have not tackled? Give them some antidepressant or non-pharmacological measures. And also, there are multiple studies that have shown that up to 60 to 70% of the patients can have one or the other sleep abnormality. There may be lack of sleep at the night. There may be difficulty falling asleep. The patient may have to get up frequently. The patient is not having good whole night sleep, so they keep on getting up in the night. And because of these insomnia, the patient may have excessive daytime sleepiness. Already, the patient is not able to concentrate and be attentive. And because of this daytime sleepiness, the patient further may not be able to do his routine simple tasks as well. So if it's those things, we have many medications which can help the patient in getting a good night's sleep. There are other non-medication related or non-pharmaceutical treatment as well, like exercising regularly, reducing stress because by using various stress relieving exercises like yoga, meditation, jogging, or aerobic exercises, and not to eat or drink right before going to bed, because this may increase the metabolism and make the patient get up frequently, and also to pass urine and all. Limit activities in bed, like watching TV, listening to, engaging yourself in bed. The mind will get confused whether the person wants to sleep or get attentive. So the patient may not have good sleep. There may be calming, atmosphere should not be noisy. The light should not be bright when the patient goes to sleep. So these measures can help the patient with HD get a good sleep, and thereby have a good, the next day morning, he will be more attentive. There may also be weight loss, like because it may be because of the increased motor activity as well as pure nutrition and feeding difficulty because of various reasons. The involuntary movement may be impeding the patient having proper food, difficulty holding eating utensils, problem with seating, difficulty chewing and swallowing may be the reason, or distractibility. The patient is not able to focus on eating and keep on getting distracted, or maybe he's not aware of the hunger, and also poor dental hygiene. These may be the factors that may lead to poor nutrition and weight loss. There may also be other autonomic dysfunction, of which one of the most common is urinary urgency. The patient has to go more frequently for urine, keep on going, and he can't hold his urine, so he or she has to immediately run to urinals. So these things the patient will have, and the caregiver should be aware of this, so that to understand that this is, some things are not under the control of the patient, and these are part of the disease which the patient unfortunately cannot do anything much about. So coming to some studies to show what is the burden or what is the problem. Like this is one of the only study which has studied the non-motor symptoms per se in Huntington disease. They used a questionnaire scale which the patient and the caregiver answered. This scale is usually used for Parkinson's disease. Unfortunately, because we don't have a complete scale for Huntington disease, so this scale was used. And surprisingly, they observed that the non-motor symptoms were way higher in Huntington disease compared to PD, like digestive problem, urinary problem, memory problem, hallucinations and delusions, depression, sexual dysfunction, heart related, sleep related. Everything was way higher. I mean, except for the urinary problem, everything rest was comparatively higher in Huntington disease patient compared to Parkinson's disease patient. So non-motor symptoms are definitely a burden to the patient as well as the caregiver, and we have to address that with medications or other treatment modalities. There are also studies that says it is not only in the patient already manifested with HD, even those who have not even had the motor symptoms, there may be previous sleep deficits may be there. There may be difficulty in decision making, cognition. So the patients at risk of HD, they may not understand why am I having sleep problem, why am I having this. They should be aware of this, and if they come across such problem, they have to consult a doctor so that they can be treated accordingly to whatever extent that we can treat. So there are few studies that we did in NIMHANS so that understand these aspects better, so that we can help the patient and the caregiver better. So this was one of the study by primarily by our team. Nikhil Ratna first author, and Dr. Sanjay Jain, Dr. Pramod Kumar Pal also as a part of the study, where it was seen that of the various factors, psychiatric morbidity, that is psychiatric problems, were one of the major driving factors for poor survival and suboptimal functional outcomes. So that is how the important the psychiatric morbidity is. If we are able to treat with whatever modalities we have and improve the psychiatric features of the patient, the survival and functional outcome will improve. So this aspect has to be remembered while treating. And also one more study by a team where we saw that sleep disturbances in patients with Huntington disease. Again, this was a questionnaire-based study which the patient and the caregiver answered. And compared to similar to other study, we saw that there are significant sleep disturbances in patients with HD, which led to significant problems in the patients and their caregivers as well. There was a difficulty in duration. The patient had lack of sleep, duration, frequent awakenings, and also reduced duration of the sleep. And one more study which looked at the reason for cognition, that is the memory. So we saw that there is excitability. This was a study. We do tandem transcranial magnetic stimulation, and we saw that the excitability, brain excitability was significantly reduced, which was the reason may be the reason for the memory impairment that the patients have. And this was one of the thesis of the project of one of our student, Dr. Jagdish Annaprudi, under the guidance of Dr. Sheshkari, Nitish Kamble, Pramod Kumar Pal, and Ravi Yadav sir, which we looked at polysomnography. It is one of the tests to study the sleep in patients of HD. But again, we saw similar to the various other studies that up to 60% of the patients had significant sleep abnormality. And this is, so basically there are not much research in overall non-motor symptoms. So in order to understand this better so that we can help the patients better. So we are doing this project or a thesis where we are looking for the non-motor symptoms and how it affects the quality of life of the patient and as well as the caregiver, so that we can understand this better and helping the patient and caregiver as well. So any person who are interested in this study can consult us, and we will be very helpful. We'll be very happy to see. I mean, so that we can understand better. So to conclude, non-motor symptoms play a significant role, not only the motor. Also, the non-motor symptoms also play a significant role in the life of patients with HD as well as their caregivers. The timely identification and their management can make their life better. So ultimately, all the treatment that we offer is to make the quality of life of the patient and the caregiver better. So that is the ultimate aim, whatever way we may end up doing it, but that is the ultimate aim of any doctor. And because we still, I mean, medical profession is still progress day by day. So still there are many aspects that we don't know. So that is why we keep doing research, and I welcome all the patients who are interested in contributing to this research to be part of the various research that we are doing in NIMHANS, so that we together can understand HD better, so that present patients and the future both can benefit from this. So thank you again for the HDSI for offering me this opportunity. And I also want to convey my appreciation for the caregivers who are actually the everyday heroes that who take care of the patients more than the doctors actually. Thank you.
Thank you, Dr. Vikram. That was a very nice talk. I'm sure many of the patients and caregivers and clinicians listening in benefited. We'll quickly move on now to the next talk. Dr. Selva is the next speaker. So he is a movement disorder specialist and a physical therapist. So he's going to be telling us about what are the mobility problems that these patients have and how it can be encountered. So he conducts movement analysis to improve mobility and prevent falls for elders with and without dementia. He delivers informal teaching programs towards this. He has been seeing HD patients and suggesting methods to improve their quality of life. So over to you, Dr. Selva.
Yeah. Am I audible, ma'am?
Yeah, make it full screen, the slide, and then you can start.
Yeah. Yeah, thank you very much for the invite. So, and I would like to thank Nikhil for before. I thank everyone because he was the one invited me to be a part of this team. So from then it started, and now especially I would like to thank you, ma'am, and Dr. Sanjeev Jain sir for this opportunity. So at the outset, what basically we do for Huntington disease in terms of physiotherapy. So I think Sir has also, though Sir has mentioned about non-motor symptoms, he has also covered it a little bit about what motor symptoms can be. So the generally they develop tightness, soft tissue tightness in terms of ankle joint or TA tightness or the contractures. So and then similarly the weakness can be present, and balance and gait issues are major symptoms we can see, and falls one of the major complaint by the patients. So these areas are basically covered by physiotherapist. Though we generally aim to make the patient more active, so that we can help them to be having a better quality of life. So before we move on to what exercise can be beneficial, I would like to introduce this model. This is what the contemporary physiotherapy approaches focus now. So the earlier model was biomedical model, where we just work on the what are the symptoms we mentioned just now, something like a muscle weakness or the tightness or the balance in gait issue. So these are the impairments. So the impairment model is about biomedical model, but there is a change by the ICF model, which suggests the biopsychosocial model, wherein two factors have been introduced, that is environmental factors and personal factors. So in order to make the person more active and being, actively participating, so this factors also to be considered. So what are the advantage of biopsychosocial model? It also give us an insight about how this mind-body connection is happening, which is also emphasize how motivation can bring about better motor outcomes. And also they emphasize on the environmental, so the need for developing a supportive environment. So these things can actually bring about a better motor control or better motor learning for the patient. So this model suits to many neurological conditions, including Huntington disease. So the advantage is like we'll have better results, hence it will save money, time for the patients. So even the physiotherapy research, physiotherapy clinical guidelines suggest that whenever we treat a patient, we need to assess with the following outcome measures, all the three outcome measures. Unlike the earlier version where we just measure only the impairments and then quantify that and focus on that. Now we need to really ensure that the impairment is actually transformed into his daily life activity as well. uh, the exercise has an impact on improving the person's is activity level as well as the participation level, whether he is able to get back to his pre-morbid role or not. So here also we need to mention the quality of care of the caregivers as well. So having following this model, it will even improve the quality of life of the person, the caregivers as well. So in the just go into the detail, the impairment model actually they have replaced the term impairment into body structure and function. So the which are primary and secondary impairments, something like cognitive functions and muscle strength. So these all will come under primary impairments, whereas the muscle strength or the tightness or rigidity related secondary impairments are called contractures, and this will be recorded, um, and then the focus also be given to the activity level to improve the daily activities of daily living, and as well as improve the participation. So these measures are done by using Berthel index and quality of life scales. So coming to the Huntington disease and the exercise program or the physiotherapy program for Huntington disease, it is totally depends upon this stage they report to us. So in the very initial stage, we may not have any issues like falls, weakness, and things like that, except maybe some involuntary movements. So that the focus will be more of the physical fitness. So just to prepare the person to be more, having strong muscles and improving the endurance aspect of it. Whereas the real problem starts most in the middle stage, wherein the falls started. They start reports about the falls. Then at that time we need to work on the fall prevention strategies. So at the later part of this presentation, I'll be covering the brief idea about the fall prevention program. So then in the later stages, actually, we need to move to the compensatory approaches. So So until then, we can try to restore the function in terms of improving the strength and things like that. But in the later stages, it has no, as the disease severity increases, we have to modify the environment to suit to the need of the person. And also the chest complications increases the need for the chest physiotherapy also emphasized at this point of time. And also, since the person is more dependent, so the caregiver also likely to get burdened. So the caregiver support is also one of the hallmark at this stage. And mostly the person require all adaptive devices. I mean, we need to modify the day-to-day things what the person is using, such as the change the grip of the regular teacup, whatever he is using. So the sort of using a universal curve, things like that, or modifying simply the chair height, such as even modifying the toilet settings in the grab bar you can install those things. And coming to the involuntary movements, very recently, I think Dr. Nitil has actually put me with one of the patients in a video call. So he was asking about the involuntary movements, how to control the involuntary movements. So the person was walking. As he walks, I think he was suddenly developing this involuntary movements. This is quite disturbing for him. So I mean, like main important thing is anxiety reduction has to be done. The person is going to get more and more get anxious about it, and he's going to further developing this involuntary movements, or the consequences of that involuntary movements will be more. So also we need to educate normalized movements. For example, a simple stepping activity. So how much the range is required for each individual joints, right from the hip joint, knee and ankle. These three joints works in certain range only. So if we could educate, it's something like retrain our brain to bring about a normalized movement. So the person is every time consciously making an attempt to bring about a normalized movement, so he can know very well, like try to reduce the devastating sort of sudden involuntary movements and related complications. So it's quite scary for the person, because the video was showing that he was walking on the road. So there are chances for no accidents and all. So since safety is very important, I would suggest even uh, having a helmet whenever they walk outside the environment, and standby one person can be there for the supervision. Along with that, this exercise also can be practiced. And other exercises which can help to bring this involuntary movements down is closed chain exercises, wherein your distal joints are not moved. For example, when you're sitting in a chair and raising the leg, these are open chain exercises. Whereas when you stand and do the squatting, that is nothing but a closed chain exercises. So there are a lot of closed chain exercises which can be prescribed to reduce this involuntary movements. And in some instance, even adding weight cuffs, adding extra weight to the limb or the extremities also helps to reduce the impact of the involuntary movements. And in general, exercise is highly effective in Huntington disease in terms of maintaining the flexibility, maintaining their strength, thereby improving the balance, thereby improving his walking and overall quality of life. So so there are different kind of exercises. So before we go on to the type of exercises and falls prevention in Huntington disease, how exercise can be helped. So exercises in general, what I mean here is even aerobic exercise, a simple walking for about 45 minutes for 5 days in a week. Also, or the strengthening exercise at least twice a week, which is recommended by the CDC, also can be very well followed in Huntington disease. So this because the exercises are actually found to be very effective even to improve the cognitive function, and some of the studies even they have found that it's improving the endurance, and so also preventing further this some of the other degenerative condition also it's found to be very effective, lower the risk of developing dementia. Also, some of the exercise like Tai Chi can improve the gray matter, can actually slow down the gray matter atrophy, and also non-motor symptoms also found to be improved, like improving better quality of sleep, as well as reduction of anxiety and depression by doing exercises. And main important aspect of Huntington disease is they often complain about the falls. So, in general, falls happens due to two reasons. One is intrinsic factor or extrinsic factor. Though we can classify into physiological factors, pharmacological or behavioral and environmental. In simple terms, intrinsic factor is your physiological system, the impaired muscle strength, or the muscle tightness, or the poor balance, or the vision. There's a problem in vision or cognitive function. These things can be put into intrinsic factor, which can leads to problem in falls. So whereas in extrinsic factor is the environmental constraints or environmental hazards, we can say those things also can attribute to falls. So if we could focus both the aspects, then only we can prevent fall in uh, even in Huntington disease. Coming to the balance and gait evaluation, whenever the falls is reported, a detailed balance and gait evaluation is needed. Some of this equipment like dynamic posturography can give a very detailed report of the direction oriented fall, which direction the person can actually likely to fall, so that the therapist can particularly train that direction oriented limits of stability training programs. But however, this dynamic posturography is not available everywhere, though we have in NIMHANS. So some of the alternatives could be outcome measures like Berg balance scale, which is a simple scale can be applied, and also for the gait assessment, Tinety gait assessments can be used. And even this gait assessment, one of the paper we presented in the last movement disorder conference in Delhi. So that negative step length is the hallmark of that gait impairment we noticed. So some of the strategies also we have planned as an intervention study we are planning to improve this aspect of the gait dysfunction. So one major area is gait variability. Gait variability is the variation in the step length, the variation in the step time. So in comparison with the normal population. So if that has been, the percentage is increased, the variability of the gait is increased, it simply translates into more number of falls. Also, it is a marker for the neurodegeneration, such as even in the dynamic posturography, whenever the mediolateral imbalance is seen along with that anteroposterior balance issue, is considered as one of the risk factor for dementia. So this already I have mentioned. So these are the external factors one can actually make a note of it. Something like a slippery surface in the bathroom. So the person better, the family members can allow the patient to use the bathroom first, and as much as possible not to make that place very wet or avoid slippery surface. And the living room can be better organized, because an unorganized living room will be a risk for falls. The poor lighting and there's a poorly maintained carpet and very carelessly put in some cables like telephone wires, or even the children's the toy items, something like a wheeled toy. Also in the society, the narrow or obstructed walkway, these all can be also can contribute to falls. So one need to work on all these aspects to prevent falls. So, so in general, what we prescribe is the range of motion, what the Huntington patients needs to do just for the recollection of all. Um, uh, you need to at least remember these things, something like range of motion exercises. This is to move your joint in a particular direction, which will be prescribed by the physiotherapist. You can learn from them to move the joint in particular directions to maintain the flexibility. As I already mentioned, is very important for improving your balance to execute the balance strategy. So stretching exercises again to prevent tightness and contractures. So if there is a poor strength on one group of muscle, obviously the other group of muscle goes for tightness. Even the involuntary movements also can bring about some shortness of the muscle. So a regular stretching exercise program can definitely maintain the joint range as well as the flexibility, which eventually help the person to have a better balance. And the splinting is very important, because whatever the stretching exercise we are doing, it may not sometimes sustain. So one may need to use the splint. Sometimes overnight the person may have to wear the splint in order to prevent the contractures. And as I already mentioned, strengthening exercises in terms of isometric or isotonic, both the exercise needs to be done. And these are the apart from aerobic exercises. And balance and gait retraining. So followed by the gait and balance analysis, you will be prescribed some balance and gait retraining program, something like dual task training or the multitask training, or the limits of stability training, or the or something like um, uh, um, and reactive balance training or anticipatory balance training. So these all exercises you may have to do it. As well as in the later stages, mainly you need to make a lot of environmental modifications in order to make his life better, so to improve the quality of life of a person. So finally, is there any role of exercise to even prevent further neurodegeneration? So this is always fascinating for me, because exercises can make some changes in the brain in terms of brain plasticity. A lot of CNS disorders we are hoping on this aspect, that is brain plasticity, even stroke or any other, even Parkinson disease. So there are actually evidence that exercises can improve the brain plasticity, as well as the process is simple. Like it is actually found to increase the dendritic expansion, new synapses forms, so neurogenesis happens. Also, exercise found to be improving the hippocampal volume. So we all must be knowing hippocampal is the area, a small portion of the brain can generally get atrophied in dementia. So whenever this exercise is done regularly, hippocampal volume is maintained. So what this conveys as is exercise in general not only improve the moods of the person, improving the endurance or cardiovascular fitness, it also can have a better effect on the brain, to even to say that it can even prevent neurodegeneration to some extent. So with this note, I would like to stop here. Before going, keep the person motivated by even more by motivating yourself. Involve the person to do all the daily activities, even though it looks difficult at later point of time, but still you have to make the person to do all the daily life activity. Like starting from the brushing, eating, all this basic activities, or even taking them out, and ensuring them to participate in the social gatherings to maintain the fitness as well as to improve the overall mood and his inclusive community aspect of it. So with this, I would like to stop here. Thank you very much.
Thank you very much, Dr. Selva. I'm sure a lot of the listeners would have benefited significantly from your talk for all the practical tips that you've given them. So we now move on to the next talk. So the next speaker is Archana. So she will be telling us things from the family perspective of what can be done. Archana? Archana is an analyst with Infosys, and she's a very dynamic person, does a lot of social work and spends a lot of time trying to motivate people to shake away all the depression and do what needs to be done. So I'm sure her talk is going to be very inspiring.
Thank
Yes,
you so
Archana.
much. Okay, I'll share my screen.
Yeah.
Are you able to see my screen?
Yes.
Okay.
You can make it full screen.
Yeah, that's good.
Yeah.
A very good evening, everyone. Like Dr. Meera said, myself, I'm Archana Ravada. I have been diagnosed with HD a couple of years ago, in July 2017, mid-July 2017. Like every other patient, it took me a while to accept my disease because of the severity of the movements and all. So I was like little shaken up after I knew about the severity about the diseases, and like why me when everyone are actually moving ahead in their lives, and why me. So I was all stuck there. So it took me little time. I worked really hard to accept myself, and it took me 2 years to do that. But post my acceptance, it actually I started this motto of helping people, all the HD patients, all the HD families, whoever are going through emotionally, mentally, and physically, so that because I was once upon a time, I was in their shoes, and I know the pain, what exactly they are going through. So today, based on all my experiences, I have been gaining in the past 6 to 8 months after talking to too many HD page families and all. So today I will be presenting you few experiences which I felt like they need to be shared with you, because they are really motivating, and they are really moving, and they are really moving. And because yeah, this is my overview. I'll be this is the overview of my PPT. It's like first thing, it will be I will be telling you about the post diagnosis and family experiences, what I felt are really effective, and the diet which has to be given to the HD patients, and the caregivers, and how the role the caregivers play in our life. And CAM is complementary alternative medicine, which I will be discussing in this slide, in this PPT. So, post Huntington's are after the patients are diagnosed with Huntington's disease. Like most of the patients which I have seen are like they fight with psychosis, emotional trauma, emotional stability, and anxiety, and not more than it's like not more than movements, not more than the symptoms. Rather than symptoms, the most of the patients fight with these depression, anxiety, psychosis. So during that time, it is actually really from the HD patient, from the family point of view, I feel that they should be there for the HD patients day in and day out, and monitor them, put them at a caution. Because if suppose say they are like into depression and anxiety, that might lead them into more depression, that might lead them into the HD patient condition and situation will be very bad. So they're to make them active, keep in touch, keep in touch with them, and keep monitoring their status day in and day out, and make sure that the HD patient is doing fine right after the diagnosis, because that is what is most important point here. And another thing which I saw is like some patients show mania leading to elevated mood, hyperactive. Mania here is like too much of anxiety and all, that would again lead to elevated mood, and again impulsive behavior, which is again not good from the Huntington's disease patient point of view. So all that should also be monitored regularly from Huntington HD patient point of view. And another thing which I came across was not me, one of the family experienced was like the patient was suffering with bipolar disorder. And bipolar disorder here, it means like people will and she was actually, she herself is a hunting HD patient, and she wasn't aware of that bipolar disorder or that whatever condition and all. So what exactly happened, the situation what happened was that uh, the family was not aware of her by BPD. So what exactly happened there was like she used to after watching the movies, she used to imagine herself in one of the movie characters and all, which led her to actually again lead into some depression and all because of that BPD. And she had to get admitted into the hospital because of that. And she had to get treated under the doctor's thing. And that again led to that was also like another tough challenge for the HD family, as they were not aware of this BPD and what exactly and her situation. It took really a lot of time for the patient to get back to normal life. And like I told you, I have been post my acceptance from my of my post my acceptance of my HD life, and my the way post my acceptance of my HD life, I started talking to too many HD patients. So it's like too many HD patients and their families. So I would like to share their experiences, which I felt really special to me. And I'll tell the first experience which here is like the family tested the family they're not aware about this family, they are not aware about the Huntington's disease. The entire family, most of actually it's like most of majority of the family members are having they are having this HD symptoms, but they were not aware that it is HD. So when his father tested, when his father had HD symptoms, chorea and all, they didn't knew it was HD. And his elder sister showed the same symptoms, and she passed away. Even then, they were not aware of that this was a HD. And last in 2020 Jan, when they took them to Bangalore and got it tested, then they came to know for his younger sister. Then they came to know that it was HD. So what happened? It was like they were not aware that it was a HD disease first thing, and the entire family was suffering. And he lost his two sisters because due to this HD, and another of his sister is suffering right now with juvenile HD. So one thing which I felt there was like they were post this diagnosis, when he and went and tried to explain his mother about this disease. His mother was not willing to accept it, and say and she was like she was so adamant to accept that about this disease, because she wasn't aware of what HD exactly is. And even the person was not aware what exactly the HD was. And they used to think that and the family members, or his family members along with his mother, thought that HD patients, the family, they are haunted. And all the family, all their family members are haunted. And they started actually giving doing some pujas and all for them. and that is actually that is another sad part here, because rather than getting aware, see, they don't know, they're not aware of the disease and all, and rather than getting some medical help and all, they are actually going to do some pujas, and they are actually thinking that there's no. And another thing, another saddest part here is like they don't know about the cure and all, and they are just thing is like they don't have any awareness, and they're not willing to accept the severity of the disease. So, and they're not that one thing which I observed here is like there's no acceptance here in this family. And the next family story which I would like to share here is s- the thing there's no none of the family people it's like again a couple of two different people whom I spoke with. They don't have any proper HD background, and it's like no family background they have, and they got tested positive. That is this is possible only in the case of where the person is actually having mutant Huntington gene. And see, people like people like us who are aware of HD a little, who has little HD knowledge and all, we ourselves are not willing to accept it, who we are not coming out to accept this disease. So just imagine the plight of the family who are not aware about, who doesn't have any HD background, and who are not even aware like what exactly HD is. Out of blue, they tested positive for HD, and they did research in Google, and they came to know about that there is no risk, there's no cure for this disease, and the chances of offspring getting this disease is 50-50%. And it was like too tough situation for both the families. And another thing is like both of them actually quit their jobs, and both the families had to quit because they were in the middle stages of the HD. So they were again worried about like what people might think after seeing their symptoms and all. So they stopped socializing with people, they stopped talking to their own family, they actually locked themselves in the room, and they also had the suicidal tendencies at some point. And the family was actually trying to convince them, both the families were very supportive. They were actually trying to convince them like, this is okay, we have to move ahead with our life, it's okay, even though you got tested positive, it's okay, we will there and look after you. But still, even after giving so much of support from the after family support also, they are like the situation is very bad, because they're not willing to accept this thing. And another family which I observed is like this is another third family story, where this is also another sad story. The entire family, they have 16 odd HD patients, and 5 HD patients died recently from past 6 months, and 15 are at risk. And they with not much medical aid, because they stay in a remote village. So they're not one thing here is with this family is like they're not willing to they're not willing to, the entire family, they are aware of this Huntington's disease, but they're not willing to accept it, because they're not willing to open up about the disease, because they are scared, and they are actually, because they are scared about the and they are and because the disease will deteriorate them gradually, and how the disease will change their lives eventually. So because of all those things, they're not willing to open up about this disease, they're not even, none of the family members are coming out. And another sad part here is like the doctors have no knowledge about this disease. When they are actually when they went to seek doctors consultancies, the doctors were not even willing to look after the HD patients. It is only because they're not aware, they're telling like they're suggesting some false medications or something like that, to this incorrect medications to these people. So another tough challenge is like the bread owner of the family tested positive. So he is actually having a business, and he has to give up his business because of his he is positive, and he's not willing to socialize with anyone. And the bread the breadwinner has gave up on his job, and now they are the financially crunch, and the situation of their family is also very bad, and the wife is literally struggling almost day in and day out for their to meet their financial expenses, and there's no mental support, financial support or emotional support for her. The only thing she's praying literally all day in and day out is for some research to come so that she will get this disease. Another thing which she is worried is she has a kid. Even her kid is also at risk. So the financial situation of the family is very bad, and her kid is also at risk, and even he is also having some health issues. So all these things and all are again this really moved me, because this the situation and all the situations are really devastating. One thing which I understood from after talking to all the HD families is like none of them are willing to accept it, none of them are willing to open up about the disease, and most of the people who are in the remote villages and all, they are lacking this medical aid. And most of the people are like they're not willing to open up and all, and they are suffering a lot emotionally, mentally, and financially. All the families, HD families, are suffering in some way or the other. And in this part, I would suggest all the HD families to seek help of each other, each and every other members in your family or outside, because we are connected as a HD, because as a HD, at least now we have this support group, society, and everything. So at least this way, I would suggest all the HD families to stay connected, so that you won't lose the hope, or whatever it is, we will be there for you in every possible way. That's what I wanted to tell all the HD families here. And those are the those are the few stories which I felt shook me. And coming to this, these are the common challenges which we face for a HD patient in the later stages of their life, after they are positive. In the, if a in the later stages of HD patient, food should be mashed with help of a blender and minced, so that it will be easy for him to swallow. And also use thickening powder to thicken juice, soups, water, etc., so that it will be easy to go down the throat. Because after some time, it will be really tough for the HD patients to swallow the normal food. That is when, in the last stages, when self-feeding becomes difficult, they can use feeding tube also. Also, patients experienced difficulty in swallowing, and choking is observed. So it is advisable to maintain a caution or monitor him. With time, the patient's ability to do that regular course will reduce. So during that time, caretakers should be doing all their daily course, right from cleaning, laundering, sleeping, feeding them, everything. Due to the due to the facial muscles and movements in facial muscles, patients will lose their ability to talk. That is when it is suggested for them. That is when it is advisable for them to go for a speech therapy. Based on the another thing is like, based on the patient stage, whether they are in stage 2 or middle stage and all, it is advisable for them to go for physiotherapy also, because it will help them to lead at least a better life for a two how many ever days that going for that physiotherapy. As the disease progresses, the movements will be frequent and uncontrollable. So it would be very tough, and also along with that, swallowing is also difficulty in swallowing is also observed. Another thing, because of the heavy movements, there will be imbalance in walking. So there are high chances of injuries due to all these falls. There might be chances of head injuries also. So please make sure that the patients are monitored regularly. Sleep impairment is observed. Both onset and wake up time are delayed. needed. So in some cases, sleeping aids are suggested. Caregivers. The best thing about what I feel today, what I feel from past 6 or 8 months experience, what I feel is like caregivers caring for someone with advanced Huntington's disease is both a privilege and a challenge, as told by Cat Stanley. This is actually I would say this caregivers play a very vital role in every patient's life. Patients are like normal. There's nothing much to do from their part, but caregivers they have to be really motivating. They have to be self motivating, and they have to be innovative. They have to be positive, optimistic throughout, because they can't vent their anger, they can't show their emotions, they can't do anything in front of HT patients, because whatever actions or whatever things they might do, it might affect them, because it might affect the HT patients. So from that point of view, all the caregivers are like positive, and they at least they try to be positive, at least they try to show, at least they try to be positive in front of the patient point of view. But caregivers they also need a lot of support, and caregivers also need lot of counseling, they also need lot of emotional and every support, whatever which is needed from our end, because they play a very vital role in your life. In the final stages, walking becomes impossible, so patient depends on wheelchair. The stages caregiver in that final stages, caregivers are will do daily activities such as bathing, dressing, and eating. In advanced stages, caregiver, another thing which caregivers is like, in the advanced stages, it is really tough for caregivers should be very strong to accept the bitter truth about like how like how we know, every one of us here are about of the last stages of Huntington's disease HD patient will be it. Caregiver should be really strong to accept that, because it will be really tough for them to see their loved ones or their kid or kin in that situation. So I would advise almost all the caregivers to be strong, never ever give up, and accept. One thing which I, like I told you, one thing which I observed throughout here is like acceptance of HD patient within family and society. Because like I told you, I took couple of years to accept myself, but at some point or the other I did accept myself, but most of the HD patients are not accepting themselves. So they should, and the family also need to accept, because family plays a vital role in every HD patient life. Because if family is not there to support, I would tell you 90% of the HD patients will suffer from suicidal tendencies and all. So family and society also, and society also should be there, because most another thing which we are facing here is like society and the social stigma. Like most of us see, everyone here are like worried what exactly society might be thinking. And because of the movements and all, more people might think that HD patients are drunkard or drug addicts or something like that. So even the society, because of that, society should also accept the HD family along with the family, which is very important. And post diagnosis, the family of the HD patient should be counseled with with proper knowledge about the disease, because they need to know how to handle the HD patient right from the day one. Because and as this is like a very rare disease, not much people will be aware of it, and not much people will have this access to internet to surf or Google. So proper counseling needs to be given by the doctors to the HD family about the proper insights about this disease. And be ready to face the social stigma. This is the major thing, which is major drawback which we are facing right now in our society, HD society. Most of the people are not willing to come out and come out with this disease. Even I myself, I was not willing to come out and socialize with people. So I know the plight of what other of the other HD patients. So here it's like we have to overcome this thing at some point or the other, because if we are not willing to go out and create awareness about this disease, just imagine how the our next generation will be. So if this is high time, I feel this is high time for us to go out and create as much awareness as much awareness as possible for Huntington's disease, because at least next generation kids should lead a much better life, if not us. Eh, at least we have to make them lead, we have to set a platform for them to lead a better life than what we are leading right now. So I would feel that we have to overcome this social stigma by creating as much as awareness as possible. And patients should be monitored regularly to help them lead a better life. Other complications in the final stages are like aspiration and pneumonia. The remedy for this is regular chest physiotherapy. And another thing which is observed is pressure sores or bed sores, like most of you are aware of it. Appropriate equipment and positioning of individual. And another thing which I have not mentioned is like when people are in the last stages of their life, they might also have some lung infections because of feeding through feeding tubes and all. So they might be having issues in lung issues and all, so even that needs to be monitored. And this is like since there is no therapeutic strategies or treatments for Huntington's disease, is not effective for HD for elevating either motor, cognitive, or psychiatric symptoms. So CAM therapy is like complementary and alternative therapies which can help to assist in improving the quality of HD patients' life. CAM is a group of diverse medical and healthcare systems, practices, and products that are not presently considered to be part of conventional medicine. These are the few of the CAM therapy. These are few of the approaches for CAM therapies. It's like manipulative and body-based approach. In this, we have massage, chiropractic, and osteopathy. In mind-body interventions, you will have yoga, spirituality, relaxation. In alternative medical systems, we have homeopathy, naturopathy, Ayurveda, as most of us are aware of it. In energy therapies, we have Reiki, magnets, and Qigong. And biological based approaches, we have diets, herbs, and vitamins. So whatever way, whichever one which you would feel comfortable for you, I would suggest you to go ahead and do some or the other thing with for your HD patient, because that would actually help you lead a better life. I am a Vipassana meditator. It helped me actually help me it's actually helping me lead a better life. I also do regular workout that is also helping me delay my onset of my symptoms. So I would suggest everyone to be physically fit and mentally strong to lead a much better life. And whichever way possible, if it is not possible for you to do workout, you can do yoga or do running, or whatever is possible, you can do that. I would like to thank you. I would like to thank everyone for giving me this opportunity. And one thing which I would like to tell you is like uh, let's fight together. Every one of us have to fight together for leading a better HD for getting a better HD communities, and for making and also for leading a better life for our future generations. Thank you very much. Thank you, Dr. Meera, for giving me this opportunity.
Thank you, Archana. I think that was an extremely emotional, motivating talk by you, and I'm sure it has touched all the hearts of all the listeners over here. And I'm sure many of the people here are going to reach out to you on a personal basis. So you're going to have a very busy schedule coming up. We hope that we are able to do it through the society, so that, many of the aspects that you mentioned are definitely some things that we should be able to do in the society in the long run. So without much, I think we should move on to the next talk. So the next speaker is Dr. Rajni Khajuria. So Dr. Rajni is a geneticist. So one of the questions that have come up in all HD families is about the next generation and how they should plan the family and things like that. So Dr. will dispel some of the doubts that we might have in this. So she is a pre-implantation genetic testing expert, and she has been working with iGenomics for about 8 years. And she specialized in reproductive, pre-implantation, prenatal, and pre-conception counseling. So over to you, Dr. Rajni.
Yeah.
Thank you, Dr. Mira, for such a wonderful introduction. And can you hear me, Dr. Mira?
Yes,
Am I audible?
we can hear you.
Okay.
Just make your slide full screen and you can go. Yeah.
Yeah, sure. Yeah. So, good evening, everyone. And first of all, I would like to thank you, HDSI, for giving me this opportunity to come and share my knowledge with all of you. This is really a pleasure for me to be here with all of you. And especially, I would like to thank Sambit, who connected me and introduced me to HDSI so that I can come over here and uh, let my knowledge be shared with all of you. I hope you will find this presentation interesting and knowledgeable. So my topic, as Dr. Mira said, I am a genetic consultant. So my topic will cover only genetic aspects, especially related to the reproductive aspects of the Huntington disease families. So the topic which I have taken is pre-implantation genetic testing in Huntington's. So as much has been said about the disease, so I will not cover much on that. We all know that Huntington disease is a progressive neurodegenerative disorder, and it has a prevalence of 3 to 7 per 1 lakh individual. Although we know that this is likely underestimated prevalence. It has two main onset, which is adult onset and juvenile onset. We know that adult onset is the most common form and juvenile onset is a less common form, although juvenile onset is progress more quickly than the adult onset. Huntington disease is caused by expansion of an unstable polymorphic trinucleotide repeat, which is a CAG repeat in exon 1 of Huntington disease gene, which is called HTT gene also. This gene is present on chromosome 4. And Huntington disease is an autosomal dominant disorder, which means only one copy of the gene is enough to cause the disease in the patient. And as this has autosomal dominant inheritance pattern, because of that, the family has the person has a risk of inheriting this disease with a 50% risk to the future generation. Huntington gene, HTT gene, it codes for a Huntington protein. We exactly the role, what is exact role of this protein is not clear, but we know that it is important to nerve cells. And as you all may know that as Huntington is a trinucleotide repeat expansion disorder, there has been four different repeat pattern has been reported for the families, for the patients, so and the individual of related with Huntington disease, which are that if a person has 9 to 26 CAG repeat, that we call this allele as a normal allele. And if there is the individual carries 27 to 35 CAG repeats, we term this allele as intermediate allele. And the patients with intermediate, the people with intermediate allele will not have a risk for having Huntington disease, but they may have a small risk to carry this, inherit this to the children. In another individual which are there for and which carry 36 to 39 repeats of CAG, we term them as they are having reduced penetrant allele. And with people with reduced penetrant allele, they may or may not develop Huntington disease themselves, but they have the same risk of 50% to inherit this to their children. Then the fourth type is that in adult onset, the individual with 40 plus repeat, and in juvenile onset, the individual with 60 plus repeats, they are known as full penetrant allele, and they will definitely develop the disease, and they have 50% risk of passing this on to their children. This is very important to know that the size of CAG repeat expansion is inversely correlated with the age of onset. That means as higher the number of repeat, the earlier will be the onset of the disease. We hear a very common term in Huntington disease that Huntington disease shows anticipation. That means the CAG repeat number, they expand in the generation. Means once a person is affected, when the person pass on the uh, repeat to the generation, it will become more. And then that person, when that pass on to another generation, it will expand with the generation. And expansion is also reported to be more often with male transmission when the person, when a male partner is transmitting this disease to the future generation. And as I said previously, that expansion is more with a large number of repeats. In Huntington disease, mostly people have an affected parent in the family from where they inherit, but rarely it has been reported as a de novo where there has not been reported any family history in the of the disease in the family. And that happen all of a means the repeat happen all of a sudden in the individual. Unfortunately, disease doesn't have a cure currently, and it affects everyone differently. Even there is a lot of variation on the age of onset, symptoms, duration, and even rate of progression for every person is different. This has been reported also that both genetic and environmental factors play important role on the age of onset in the people with Huntington disease. Counseling, this is really important slide. I would say that more to stress upon that this has been, as we know that there is a quite unpredictability of age of onset and also of clinical prognosis in Huntington. So as a part of good clinical practice, accurate interpretation, proper psychological support, and a compassionate counseling of genetic test and its result is really, really important. And in Huntington's disease, the three main area where the counseling become really important is at the preconceptional level when the patients are planning for their reproductive options, and also about genetic counseling where a pre-test and post-test counseling should be involved. And then psychological counseling has a most crucial role in with counseling the Huntington family. For genetic testing in Huntington disease, we know that genetic testing can help to determine your chance for developing Huntington or passing it on to your future generation. People at risk usually find it very difficult to make a choice whether they should get tested or not. Many individuals think that there is no benefit that I should test myself, and because I'm not going to get affected right now because I may develop the disease later on in later generations, so it's not important. But there are other individuals who want to end this uncertainty and they want to make an informed choice. But this is important to know that whether you want to get tested or not, that is completely person, and this is the right for the individual with the disease to decide on this. The most effective and accurate method of testing in Huntington disease is direct genetic testing, where the blood sample is taken from the individual with Huntington disease, and the CAG repeats are counted in the gene, and finally, based on the repeat expansion, it is informed whether the person is affected or not. Psychology, as we said, this is quite unpredictability of the onset and clinical prognosis. This is really important that a psychological impact of predictive genetic testing for the individual and their family member should be taken into account, and they should be counseled accordingly. Genetic testing for the children is typically prohibited before the age of 18 years. However, this has also been stressed that a child under the age of 18 may be tested to confirm a diagnosis of juvenile onset after a thorough neurological exam. Coming to the reproductive options family with Huntington disease has, for the people who have family history of disease and they want to have a child, there are different reproductive options based on whether they want to know their own status or not, whether they want to monitor the pregnancy, and they can go for prenatal diagnosis where the woman is already pregnant and they want to test the fetus to know whether the fetus is affected or not. They can go for pre-implantation genetic testing, which I will be covering later on in the further slides. Individual can opt for sperm and egg donor to avoid the disease transmission, and also they can also go for adoptions. This is the same slide, which again, as I said in the previous slide, that the decision of your reproductive option is completely your decision, and it will be based on whether, so your counselor can give you a particular option whether you want to know your status while getting your like while you want to test your future generation, whether you want your own status to be known or not. If you want your own status to be known, you can directly go for a direct testing using a prenatal or PGTM. Or you can also, when we know that the person is not carrying the disease, there is no requirement for the testing of the disease. And when you want, do not want to know your own status, you have different option of non-disclosure PGTM and exclusion testing using prenatal or PGTM. What is prenatal testing? And as you all know, prenatal testing is basically when the lady is pregnant already, and they can get the fetus tested to know whether the fetus is carrying the disease or not. For Huntington disease, prenatal testing can be applied in two different methodology. First is direct method, and another one is indirect method. When we are using direct method for prenatal testing, it again, as in predictive genetic testing, the expanded allele is tested directly based on whether the fetus is carrying the expanded allele from the at-risk parent or not. And direct method is the most accurate method for the testing. When we are using indirect testing for prenatal, we call this as a prenatal exclusion testing also. This is important that in this method, it allows a couple to have a child free of disease without learning their own genetic status. Mean it will not disclose the person whether the parent which want the testing to be done for the fetus, whether he or she himself or herself are affected or not. In indirect testing, we use linkage analysis strategy, and we use PCR using informative STR marker that are linked to the disease. And it is very important to know that in exclusion testing, a sample from a very closely related affective relative, especially parent of an at-risk person, is required to identify the marker close to the Huntington disease gene. So mostly a grandparent sample is required, and this will determine if the fetus has inherited the at-risk allele from affected grandparent or not, and based on that only, the report will disclose the result. But the drawback of using prenatal exclusion testing is that unaffected pregnancy may be terminated if the parent at risk has not inherited the grandparental allele, which can lead to serious moral and ethical objection. And more problems can occur if afterwards at-risk parent finds out that he or she is not a mutation carrier themselves. Coming to pre-implantation genetic testing, what it is. And pre-implantation genetic testing for monogenic diseases is called as PGD also. Previously, it was termed as PGD. Now, a new term is called known as PGTM. PGTM uses IVF, in vitro fertilization, where IVF consultant uses the egg and sperm of prospective parent, and they create embryos in IVF lab. And later on, these embryos are tested to determine whether they are affected or not. And the test is custom designed for each and every patient for specific mutation they have in their family. This minimizes chances of having no results or misdiagnosis due to the allele dropout. IVF cycles for PGTMs are only planned once the result of pre-PGTM is available, which I will discuss later in my next slide. Once the embryos are tested and found out that embryos are unaffected or affected, only unaffected embryos are selected for the transfer to the woman's uterus. So what is the benefit of PGTM and why it is, how it is different to prenatal? That because PGTM is done at a pre-implantation level, it significantly reduces the risk of having single gene disorder for patients which are at risk to have affected offspring. It helps couple to build a healthy family. It is very important fact that it is done before pregnancy is established. So it helps to avoid difficult decision and situation like termination of pregnancy, as it has to be taken care in prenatal diagnosis. And it has an accuracy of more than 98%. How PGTM is done, as I have already briefly covered in my previous slide. This is a overflow of the whole process. That first of all, as you can see, I have given with number 1, 2, 3, 4. So the first of all, we get a request for the from a patient or from directly from a clinician, mostly from IVF consultant or a gynae or a reproductive consultant, that they have a family who has a Huntington disease, and they want to know whether we can help them to uh, offer any testing to choose unaffected embryos. So first we request them to give the proper history of the family. We do study the genetic report clearly, discuss more detailed history with the clinician along with the patient, and then we give them a pre-test counseling explaining each and every fact about the test. And that also is bifurcated into two parts, that IVF and all procedures related to IVF will be counseled by the IVF consultant, and we will take care of only genetic part, where we have to tell them about the genetic test, its pros and cons, so that family should be aware of each and everything. Once the family get agreed on going through this process, then only a sample from the family and the family members, especially grandparents, are required. And we do plan a pre-PGTM, which is a personalized analysis based on the mutation found in the family. And this personalized analysis of pre-PGTM take mostly 2 to 3 weeks or 6 to 8 weeks for creation. Once this workup is done, where we just establish the informative marker for the family, so that we get ready with this information to be tested on embryo, then we release the report of pre-PGTM to the consultant, so that they can share with the family. And then after that, the IVF is the woman is stimulated for IVF. They create embryos using the egg and sperm of the couple, and then after day 3 or day 5 of the development of embryo, they take out a skilled person, embryologist, take a small sample of the embryo. Few cells are taken out from the embryo, and they are dispatched to a genetic laboratory. It can be that the laboratory has its own genetic testing, or the clinic has their own testing center. Sometimes they outsource it, they send it to other genetic laboratory for testing. So it is shipped to a genetic laboratory, and then the genetic laboratory do the testing of PGTM, and they give the report. And after giving the report, a post-test counseling is given to the clinician also and the patients also, because many time we don't deal directly with the genetic consultants. Most of the time the IVF consultants are dealing with us, and they do not have much information also how to counsel the patient further. So they many times the counseling session is conducted in a way where the consultant and the patients are together on the same call, so that they can understand all the aspect what the report is telling. And after that they understand each and every fact, and if there are healthy or unaffected embryos found, they are transferred by the IVF consultant, and then we do follow a pregnancy follow up also with the consultant to know what is the outcome. For Huntington disease families, there are 3 different options for going for PGTM. PGT, they can go for direct testing of the embryos, or they can go for non-disclosure testing, or they can use exclusion testing. In direct testing can be only possible for those families where the at-risk patient already know their own genetic status, and they do not want to go for a termination of pregnancy, and they want to avoid prenatal, and that's why they choose PGTM, where they can just select the unaffected embryo first and then implant it accordingly. Another 2 methodology, non-disclosure and exclusion testing, in both of them, are used for those patients who do not want to know their own carrier status and want to not pass on their disease to the future generation. So what is non-disclosure PGTM? Non-disclosure PGTM, although it is done by few labs around the world, it is when it was started. After that, there have been few objection on this kind of PGTM. So it is rarely used. So, but I would like to wanted to tell you what exactly is and why it is not encouraged. So in non-disclosure, generally the IVF consultant, they will not reveal any information about the IVF cycle to the patient. They will just do a cycle and they will only transfer the embryo without expansion, if there are any. Doctor will never reveal the parent status also to them, that whether they are carrier or not. Even parents, the couple, will never know that how many embryos were affected and whether how many were even implanted or transferred in the woman's uterus, because nothing has to be disclosed in this PGD. A mock transfer is performed in case there is no embryo available for transfer, or also in case all embryos are found affected, the consultant will do a mock transfer. Otherwise, if it is not performed, the patient would draw a conclusion that he or she may be carrier. However, implementation of this method, as I said, that it is rarely used. It has important practical and ethical concerns. Also, it most of the reports says, or literature says, that different scientists and the clinician has objected that as the in case the patients are non-carrier, they have to unnecessarily go through the IVF and PGD cycle. So that because of these reasons, majority of PGD labs do not offer this, but few labs offer this technology yet. Another approach of PGTM is exclusion testing, which is widely used and widely preferred over the non-disclosure due to its implications. And it is also used only for couple where the partner at risk do not want to wish to be tested. Neither couple nor the embryos are tested for the allele. But this also has a disadvantage that embryos which are found to be high risk for disease still have a 50% chance not to carry the expanded allele and could actually be unaffected. Therefore, this method can result in having a lower number of embryos that are found to be safe for transfer. One consequence also of not terminating a pregnancy at risk would be that if person at risk develops symptoms of Huntington disease, this would increase the risk of to the child from 50 to nearly 100%. So moreover, the right to know of the child would be violated. So this also has ethical implications, which are important. And so because of that, whenever patients comes for these testing, all these counseling has to be given to the couple so that they know all the aspect of the testings. So PGTM, although it has some benefit, it has some limitations also, that it is linked to that, as we know that IVF cycle has to be performed. So which will be, so PGT can be only successful if we have a very good number of high quality embryos in the cycle. So in case if a patient have poor ovarian reserve or poor quality embryos, that can reduce the success of having unaffected embryo in the cycle, in first cycle. So PGTM is also only, it is very important to know that, because this is most common concern, many clinicians ask that, okay, they can offer PGTM to everybody. No, PGTM cannot be offered to everybody. It can be only offered if there is a history of disease, and also if there is a identified mutation in the family based on what kind of disease is there. PGTM also has a small risk of misdiagnosis, which is comparable to any molecular genetic technology, like 1 to 2%, related to contamination, recombination, and allele dropout, which is a common problem in PGD. So this is again another very common aspect we get to know from patient. They ask for this query commonly, that whether we are going to check something else also doing PGD. no, the PGD will only and only is done for that specific mutation which is identified in the family. Nothing else will be tested. And another important limitation of PGD is a cost factor, because an IVF cycle has to be performed along with the PGD. So some families may not afford this and may go for another options like prenatal. In some country, it is important for you also to know that PGD is not that it is available everywhere. For many diseases like late onset disease like Huntington disease, and many countries prohibit the technology and they regulate they give the authorization on case to case basis, based on they have a national committee which approve their request. Then only a laboratory can offer the testing to the couple or the family. So finally, coming to the concluding remarks. So as we understood from the slide, that the decision to have a family comes with a great deal of responsibility and important choices. So the families who want to wish to have children, they have many options, many of which prevent the inheritance of the disease. Reproductive options available to the couple. There are many reproductive options are available to the couple that want to know their disease status, and also to those who do not want to know their disease status. But it is important for everybody to know that there is no single best reproductive option for the couple at risk. So they have to weigh the respective pros and cons of the option, and this is completely a personal, and only the final decision will be the family's decision. Genetic and reproductive education of the family and caregivers should be improved to facilitate well-informed preconception decision making, and to avoid difficult decision under time pressure and stress in the pregnancy. And as we said, and we heard in others, it is said by Archana also, that having or availability of expert counseling is crucially important for Huntington disease families. With this, I would like to thank you all, and I hope you find this knowledgeable. I will be here for if you have any question further for this. Thank you, Dr. Meera.
Thank you very much, Dr. Rajni. That was a very informative talk by you. I'm sure many new doubts would have arisen in many people's minds, and I'm sure they'll reach out to us in the chat box, and I hope we'll have a few minutes at least for some discussion at the end.
Sure, sure.
Yeah, thank you again. So I now call
Pleasure.
upon Dr. Ashwini Thakur. So as we know, he is a scientist different from all the other talks so far. So he is a professor in the Institute of Technology, Kanpur, and he is in the Biological Sciences and Bioengineering division. So he has more than 15 years of work experience in the area of protein aggregation in neurodegenerative diseases. So he looks at structural aspects as in biophysics, and looks at how biopharmaceuticals work, I believe, with the Huntington protein. So without any further delay, I call upon Dr. Thakur to share his work.
Is my screen visible?
Yes, yes.
Okay.
Yes, yes, yes.
So first of all, thank you very much, Dr. Meera, for giving me this opportunity to talk in HDSI. I'm very happy that such an organization exists, and we can work a lot in future, and I'm looking forward for it. And the title of the conference is Huntington Disease. What does it mean for me? And to me, it is to delay the Huntington clumping process. So I would like to tell you that my involvement with Huntington disease research actually started in 2002, and then it continued up to 2008, when I completed my PhD from Institute of Microbial Technology, and I wanted to contribute to the disease area where my specialization of molecular biophysics could really cater. And after coming to IIT Kanpur, I am still continuing my research in Huntington disease. Although I face a lot of challenges, and probably those challenges I will not talk. Those are mostly related to project funding, etc. So my talk will be a little different than what other speakers have told about. I will try to reduce a lot of technical jargon, but I will talk at the level of proteins. So for all of persons who are attending, just for their knowledge, that when we talk about proteins in general in the cell, they are sort of soluble in nature. Okay, so and they need to have a proper shape so that they can eventually function. And there are around 1 lakh such proteins in our cellular system, and they work for different functions. But sometimes what happens due to mutations, for example, in Huntington disease we are talking today, they try to misfold, and eventually through a very complex pathway they can make long fibrous structures which are either toxic to the cells, or they can simply, in other organs such as kidney or liver, they can simply make these organs malfunction because they deposit in extracellular space of cells. So when we talk about Huntington gene, Dr. Holla, Dr. Wadia, Dr. Rajni have already told about the genetic expansion in Huntington gene, which codes for these repeat sequences, which are known as CAG. Now, the outcome of these CAG repeats is translated into Huntington protein as glutamine expansion. And there is a number, the number corresponds to whatever CAG number is present. Equal number of glutamines will be present in the Huntington protein. And that's what I am representing here in this bar. So this red portion has that repeat expansion. In the protein, it is glutamine. And chemically, these glutamines, when stretched to a longer portion, such as glutamine 50, glutamine 100, glutamine 200, or one can say beyond threshold length of CAG in Huntington gene, they start accumulating with each other. So the solubility which I was talking about in my first slide will not be there, and slowly and gradually, depending on these glutamine lengths, the protein will start aggregating in the neurons. And eventually, they will start looking like what I'm showing in this figure and known as inclusion bodies. So essentially, they are clumps of this Huntington protein and with other proteins which are also involved. So which eventually leads to cellular abnormalities. Technically, they are known as transcription, mitochondrial problem, axonal transport, calcium signaling, proteolysis. So all kind of problems may come, which eventually degenerate the neurons, and all the symptoms of the disease will start appearing. So the treatment and cure hypothesis in this disease which is widely appreciated throughout the world now, is that pathogenesis of the disease is caused by the Huntington protein aggregates buildup. And therefore, if one can inhibit that process of clump formation or clear those clumps, most likely will delay the onset of the disease as well as the progression. Okay, so now the question comes, we cannot work directly on the patient's brain, or we cannot study such proteins. So how we will do that as a scientist, as a basic scientist? So what we try to do, and which is very good about this disease, we use different kind of model systems which scientists have developed over the years. And those are, this Huntington gene can be put in, say, neurons and can be cultured in the laboratory condition. Okay, I'm showing this figure to appreciate this particular point. And we can simply use yeast, which we used for baking breads. And we can also use some flies which loves fruits and known as Drosophila. So this gene, which is mutated form, can be put in these organisms. And interestingly, many features of the disease are created in these model systems. Okay, so we have a advantage to study disease phenotype, disease process, and pathogenesis caused by the clumping process. And more interestingly, if we take the fragments of this Huntington mutated protein or the wild type protein, this protein spontaneously, these are some names, but these proteins spontaneously, if you take in the test tube, put it in water, dissolve it, slowly you will start seeing these clumps coming up in front of your eyes, and even your naked eye, you can see that the coagulation behavior of this protein is happening. And this behavior is also glutamine length dependent. It means if I have a peptide fragment or protein fragment of say 50 glutamines, it will very quickly aggregate. If I have say Q15, it will take 1 month for aggregation. If I have Q35, it may take 7 days for aggregation. So we can visualize such behavior by even looking through eyes and then molecular details by going through very sophisticated methods which we employ in our laboratory. So what we have understood about clumping process of Huntington at molecular level, which then makes a very strong case of drug discovery and drug design, which we think that can be a better option for treatment and cure strategy. So what we have understood over the years is, and this is we studied in just test tube to understand the clumping process. We found that this is the soluble state of a particular protein, in this case Huntington, which is normal as well as the expanded one. But slowly you will see these cartoons are representing different states of that clumping process. And finally, this represents the aggregated and fiber formation. So this is schematic, came from hard work of 4 or 5 years of mine. And then to appreciate it, one of the data which I'm showing here, that look at 0 hour, when this protein is just put in the tube, you will not see anything. This is an electron microscopy grid where we are trying to understand this clumping process. But slowly you will start see these small assemblies, round assemblies which are coming up. And then these assemblies are becoming bigger and bigger in this picture. And look at this fibrous structure, which is coming after 100 hours. And this is the protein state which we have understood to the point that each and every part of this protein and what is its state and how it is evolving with time, we have clear picture of. Okay, so having understood this mechanism of clumping, we then made a case that we can use therapeutic strategy to inhibit this clumping process and at very critical sites. For example, this green site, for example, this particular site, and at this particular site. So in a way, we would like to interfere the assembly pathway of these clumps. So we found very good drug-like lead molecules in our laboratory. One of them is just amino acid, which is known as arginine, and we have arginine in our body, and its derivatives such as ethyl ester. And we found that this particular molecule and this series of molecules can interrupt the assembly of Huntington clumping. Normally it should clump like this, but in presence of these molecules, it won't clump. And that's what we tested by different methods. And in all these models, which I have already shared with you, so therefore made a very strong case of discovering of a molecule which can stop or inhibit the aggregation process towards clump formation of Huntington. We have also made series of discoveries for this molecule, which is known as calmidazolium chloride. This alone inhibits the aggregation process. It interferes with this blue part of Huntington protein. And we also complexed it with BSA, which is one of the blood protein. In humans, it is known as HSA. And then we also made nanoparticles of it so that it can be delivered to brain. And it also inhibits the aggregation and clumping of these aggregates. In another design, what we understood from this assembling pathway to design similar kind of analogs of the protein itself. So these are fragments of Huntington, but they are further mutated to the level that they will not allow themselves to aggregate, But when they are present in the aggregating Huntington protein, they will interfere with these assemblies here. Okay, and you will appreciate that in one case, which I am representing here with the value of 100 means that the protein Huntington is 100% soluble, although it is mutated in the presence of one of the inhibitor. And that's what we finally wanted to achieve. So alone, this protein aggregates and clump within 40 hours in this experiment, but in the presence of one of these inhibitor, it did not aggregate at all. And that's what I meant from the very beginning, that we would like to stop this clumping process. So in parallel, what our aim was from the very beginning when I established my lab, that for the world, we will also start working in parallel for delivery of the newly discovered molecule, either in our lab or in other labs throughout the world, to provide a non-invasive solution to the patients in future. So what we are trying to do, we are making nanoparticles now, which will be loaded with some of these discovered molecules. They are coated in such a way by utilizing those materials which are already FDA approved. So if we do that, then we will encapsulate our drug molecule here, like I'm showing in a cartoon over here. And then what it will do, it will cross the blood-brain barrier and reach to probably the sites where these aggregation reactions and clumping reactions are happening. And I will show you small, in terms of these small spheres, these are the nanoparticles which we were able to synthesize. We incorporated some of the molecules which shows inhibition and also showed activity in our model systems of Huntington disease. And interestingly enough, I am not showing you all of the data. They are showing very good result in terms of efficacy of locomotion problems in Drosophila model and other cellular system to reduce the burden of the aggregates. And recently, our one of the arginine work is also validated by one of a very leading group of Japan, Nagai, who validated our arginine work on other polyglutamine model on the mice model, which anyway we wanted to do, but we are very happy that whatever we discovered on the basis of mechanistic understanding is proven in the Huntington disease model of mouse. So I will not take your much of time because I was told that we have 15 minutes. So I made my presentation in that way. So these are some of our contribution for over these years where we have contributed immensely in understanding the mechanistic details and biophysics and structure of this aggregation pathway and design of inhibitors. And we are continuing doing this particular research. And my summary would be that it is very important to understand the fundamental underneath mechanism. If the clump formation and aggregation burden is related to the disease, on that basis we can design different kind of molecules. I have given you some of the examples. What we will do in future now, we will go for preclinical studies and see whether these molecules will be efficacious and also reduce some of the symptoms of the disease. And my suggestion to the group further would be that we must keep evolving HDSI group in different specialization, because I am at least very much excited about this organization, and we must continue supporting the patients and their family. Very important point is fund generation for cutting edge research and all other areas of HD, whether it is patient care, whether it is insurance or all other departments which will take care of eventually patients is very, very important. And I was hearing many questions about Ayurveda medicine, natural therapy, etc. I think we can involve Ayush department. They keep on funding such research nowadays, and many scientists know about this. So we can definitely involve, HDSI can directly involve with Ayush for funding in different areas. And we should keep on advocacy to the government and funding agency about this disease, and as a researcher, and to make a huge difference in family's life and patient's life especially. So with this, I would like to thank my students who did this wonderful work for 10 years now. And some of them have gone to the same area and probably they will come back and do research in Huntington disease itself. And I would like to thank HDSI again, funding agencies ICMR, DBT, and DST for giving me this opportunity to talk about this particular problem. Thank you very much.
Thank you very much, Dr. Thakur. I think that was a very, very illuminating talk. I know that you have simplified it so that more of the people on this forum can understand what you're saying, but I'm sure many of them feel encouraged that there is some effort going on to alleviate their suffering, and if at some point we will see some drugs coming up other than just the genetic ones that everybody is talking about. So I think there were some questions in the chat box which the concerned speakers have been actually addressing. Dr. Jain, would you like to say something?
No, I would just like to thank everybody for this very broad and in-depth and very engaged participation, from the personal accounts to help with day-to-day affairs, Vikram's account of an overview of the non-motor symptoms, and lastly with Professor Thakur, because one of the aims of the HDSI is to convince patients and society at large that we can contribute to every aspect of the disease, from the basic science to the social welfare. And good community care involves participation from every segment of society, from scientists, from doctors, from family members, and the patients. So, and this we hope we made a specific effort to invite Professor Thakur, and thank you for agreeing. But over time, we will be doing more of these talks with more scientific inputs, and hopefully engaging some of these with medical colleges and specialist forums, so that everybody gets convinced that it is a disease which modern science should be able to tackle. Yes. And there is reason for optimism, and that optimism the families will feel much more strengthened and confident that yes, although we may have the disease, the future is not gloomy. So thank you very much, everyone, for participating, from Selvaraj's tips on how to avoid falls to every small thing that we covered. Thank you all.
Yeah, I think today's talk was very, very. I mean, all the talks were very good. So though I think Selvaraj had got, so though we have overshot the time, but I think it was a very useful session, and I'm sure everybody benefited. So we will.
Thank you, Archana, for taking the time and for describing your own personal and your friends and your people that you meet, because that is really what makes this so imperative that we do this as soon as possible.
Yeah. So all of you have separately said that you're very happy with the HDSI. So I'm hoping that you would all engage in a more continuous basis so that we can make this society more useful for everybody who joins in, and all of you share your experiences. It will be a very, very we'll grow faster, because it's very important that everybody benefits from this whole exercise. So is there anything that anybody else would like to say? For a few minutes, I will ask any of the other people who are still here. Does anybody want to say something?
Yeah, hello, this is Dr. Ravi.
Yes.
I hope you remember me. I was there last time, HDS.
Yes.
So I attended the entire yesterday's and today's sessions. I enjoyed them a lot. And what I feel is, it's taking the right direction. And hopefully every year we'll add on more talks and more people in this. One thing I would like to suggest, that what we lack right now in HD field is more collaborative research between the neurologist or the medical people and the core scientist. So that we have to look into in near future, that we bring them together. We can do more patient-oriented studies, and also we make more resources. So I think that will be a good way to get forward. And also I would like to congratulate Dr. Ashwini Thakur. Wonderful work, and we look forward that soon the preclinical trials starts, and we look forward for alternate ways, apart from genetic ways, other ways in which we can have some cure for the disease.
Thank you, Dr.
In
One,
fact,
yeah,
sorry,
sorry
in
to
fact,
interrupt.
after today's talks, I felt that HDSI can have a discussion group every month, and one topic can be selected, and people can all participate. Because I could see today that everybody was struggling to finish what they wanted to say in 20 minutes, and there were a lot of people who were asking questions. So if we have like only one presentation, and people also chip in, I think that may be something that we can try out on the HDSI platform. It's just something that I thought is something we could try.
Yeah, I think that is a good idea, because we have so many different topics, varied topics, which can be discussed at length if we give them a particular slot every month.
Yes.
And I think I just want to add one thing, that we need to strategize to a great deal, that how to move ahead. While talks, everything is one part of that strategy, but how to move really forward. Like Dr. Ravi said, that we need to connect with each other. We need to prioritize the research, and in all other areas as well. And that should move very strongly. And we should also involve many other people. Like, for example, I know many researchers who are working on Huntington, but we are all scattered. So we can make a plan to do a great research, maybe focus on Indian patients, maybe. So there are a lot of things which can happen. And I would say that we should make a strategy group which can meet formally or informally and brainstorm the great ideas and how to really move ahead. That's what my suggestion is.
Dr. Thakur, I have a question. Now, you are discovering something at IIT-K,
Right.
and when it goes to the typically FDA-driven trial cycles, is going to take decades. Is there any way to accelerate that, squeeze it, by running a trial on Indian patients, so that the FDA cycle or EMA cycle, we can, cut them down?
Very true, actually. So, see, as a scientist, as a professor, we try to do, lot of discoveries. And I have come to a stage where we have some molecules, and I have been thinking now how to move ahead. So there are a lot of questions in my mind. I mean, first of all, I wish to go, but there are so much funding crunch. No one is ready to give funds for doing even preclinical studies. So that's what I was trying to emphasize, that if we as a group can push forward, maybe we can talk to DBT, or we can talk to ICMR together as a group, and have a special funding only for HD. So in that scenario, probably we can think more about how to do that translational research. Otherwise, ideas are all there. We know what our approach is, how to go for preclinical, clinical studies. All those can be chalked out. That is not a problem. To me, the biggest hurdle is a great funding. Although government has been very good with me, I could raise 1.5 crore rupees on a disease which I struggled a lot with people, that no, it is present in India, and if it is not diagnosed right now, it is going to be there, and I am seeing that. So it's not that I did not get funds, but for clinical trials and preclinical studies, we need quite a good money to go ahead. And those are the things which I am trying to highlight, that we have to strategize, we have to funnel our path, and then how to fund it. That is very, very important. People are there, expertise are there, will is there, and this group is there now. So I am very strong that together we can make a difference, even raising the funds.
I think as a first step, we should have a research conference meeting. Anyway, everything is virtual now, so it should not be very difficult.
Right.
So, for example, we set these 2 days aside. We planned it just over 3 weeks. So, since you have connection with all the other scientists who are working on HD, we can just have a small HD research-based conference to connect all the people who are interested.
Right.
And similarly, I was chatting with Dr. Selva whether we can make a video, for example, to show the patient families what are the exercises that may be useful. So little things like this, I think, will go a long way to take this whole, small steps in the journey, but I think we'll get somewhere, and patient families will, realize that, okay, something is being done, and everybody will feel a little better, and we'll, make life easier for all those who need help. Anybody else? I think everybody's exhausted. It's been a long day.
It's been a long, intense session. So
yeah, but I think it was very good. I'm very happy that it turned out this way. Thank you very much for all the speakers. I must thank especially Chitra and Shatabdi and Bobby, who have been working very efficiently and tirelessly to make this all happen. So this is our first Zoom conference, which you may not have realized, because they've been working behind the scenes and making sure that, it all happens without a hitch. So I thank them very profusely. And of course, I thank all the participants who have logged in, and there were some technical glitches initially, and we had to share the link again and all those things. But I think eventually enough of us were able to log in and register and benefit from this. So we will put the videos for both the days up, and we'll put up the link on the HDSI website, and also hopefully share it to all the participants who have registered. We have all your email IDs, so we'll keep in touch. So meanwhile, take care and be safe and remain positive. Something will happen. We'll all get better this way. Okay. Bye.
Thank you. Thank you, everyone. Thank you, everyone.
Thank you, ma'am.
Thank you, ma'am. Thank you.